behavioral health of the House Committee on Healthcare to order. And I will open a work session in order to adopt the rules of the committee. May I have a motion?
Perfect. Chair Greenlick, I move to adopt the proposed subcommittee rules dated 9/17/2019.
There is a motion to adopt the subcommittee rules. Is there any objection to that motion? If passed, we have rules, then we can go on in an unruly manner, even with our rules. And I would like to combine the introduction of our members with, I've asked each of the members to think about 3 to 5 minutes, talk about where they are going into this. This is a wide open discussion in the subcommittee. We tend to work together to figure out where we're going. So I thought if we maybe have a chance to contemplate where we start, then it might give us some insight into where we're going. We're going to have an hour meeting today and an hour meeting tomorrow. At the end of tomorrow's meeting, we're going to have again, we're reserving a little time for discussion to get the feeling of the committee members as to where we ought to be moving forward as we do between now and the beginning of the next session. Would you be willing to start to introduce yourself? I'm going to start with the 2 vice chairs if I have 2 vice chairs. Yeah, I do.
I am happy to start, Chair Greenlick. Thank you so much. So my name is Representative Tiffany Mitchell. This is my first term representing House District 32, which is essentially all of Clatsop County down to about 3rd Street in Tillamook County. And then we also have portions of Washington County, the Banks and Gaston area primarily, and I was just telling Rep. Moore Green, we also have a little bit of Yamhill County, but we have trees there. So anyway, in terms of what brought me to the legislature and what makes me passionate about this particular area of policy that I'm really looking very forward to exploring as part of this committee and as vice chair is just the idea that especially out in coastal regions, but all throughout the state of Oregon, we really struggle with this issue and how it affects Oregonians. And I worked in social services before becoming a member of the legislature and worked in a way with parts of these populations that really just struggled with different areas of their lives. And part of that had to do a little bit with some of, for some folks, behavioral health issues and mental health issues. And that really started this idea for me about trying to figure out where are the deficiencies in this system. And I really wanted to just be a part of that solution, and that in a way helped push me into wanting to run for this position. So that's a little bit about my background in terms of what I hope to help contribute to this committee and to learn about is, again, the deficiencies in the system. If somebody is struggling with a particular issue, what brings them into the system? Are we being able to reach them? What issues do we have with providers in trying to make sure that they can properly provide those services? What keeps somebody coming back for treatment or keeping them in the system? What kind of supports do they need? Those are all things I'm very interested in trying to overcome and understand myself. I've already begun some of those conversations locally in my own district and trying to put together some folks. I'm getting a list together of folks right now actually in my own district to try to kind of have my own little work group to talk through some of those issues so that that's something I can bring to this committee and contribute to this conversation. I'm hopeful that the more that we understand about what those problems are, the more we can kind of do this big think session of figuring out what would we actually need to move forward and fix these issues. And my hope is that by involving all of those stakeholders, we can get a really good idea of what might work and to actually try those big ideas.
Thank you. Just for clarification, there's a lot of confusion about language and what behavioral health and mental health and
They are different, yes.
for the purpose of this committee, it's my understanding we're talking about both traditional mental health services and substance use disorder services. They're combined when we talk about behavioral health. And at least until I hear any differently, that'll be the assumption from this committee. We're talking about those not as two separate things, but as one system. Representative Hayden?
Thank you, Chair Greenlick. I'm Cedric Hayden, State Representative, House District 7, which encompasses part of the Lane and Douglas counties, mostly very rural towns. I think there's about 22 municipalities in the district that I have the honor of representing. And access to health is a big issue in rural Oregon, as it is in other more metropolitan areas. But when it comes to behavioral and mental health services, the access to those services becomes critical. One of the things that through my 25-year career as a healthcare provider have been frustrated with in our system, and so I'm hoping that this committee can actually take a holistic look at our mental and behavioral health system. What I mean by that is we spend a little over $3 billion through different sources of funds in Oregon on our mental and behavioral health system, but I don't know that we really have a good feedback loop to know whether those funds are efficient. Are we doing the best that we can for our people? And one of the examples that I use is through our system. If you're on a state assistance and you end up in a county jail, you lose continuity of care. If you have a mental health service for you to keep you on that through our judicial system or through the county jail system, you go to a new system. If you become a person that then is sent to our state institution, you then have a different set of health care. And so I'm hoping that we can use this committee to look at our system in a holistic approach, that we can entwine those revenues and put a priority on not just location, county by county where they're taken, but more of a client-based, and have something that follows them through from their chronic to their acute mental health situations to the behavioral health situations. I think we've got to come up with looking at our systems that we have. We do have quite a few systems in Oregon, but I feel like it's kind of the last frontier in healthcare that we really haven't tackled as a coordinated effort. So I'm hoping that we can create some building blocks to have a coordinated mental and behavioral health system that has the client in mind rather than siloed systems. So that's one of the big things that I think that this committee will have the opportunity to build on.
Thank you, Representative. Representative Salinas? Representative Salinas is our boss. This is a subcommittee to the Healthcare Committee.
Thank you, Representative Greenlick. I am Andrea Salinas, State Representative for House District 38, which is Southwest Portland and Lake Oswego. And yes, I'm the chair of the Healthcare Committee. And I feel like Representative Hayden just took everything I was about to say, but I'll elaborate a little bit more. We have been talking in the Healthcare Committee for a while that this feels like a very isolated system from the rest of our healthcare system, and that we are going to need to look at some big picture items, I think. To start off with, I would say that my short-term goals for this committee is to look at the behavioral health system, and our workforce? And are there any policy changes that we can make going into the 2020 session prior to looking at some of those bigger picture items that Representative Hayden was talking about? So to put off, and I'll just say it, to put off any kind of payment reform until 2021 in our next budget cycle. So really in the interim, I want to start looking, and I had planned to put a small work group together just on the workforce piece, because I do think that we need to figure that piece out along the continuum of care, and whether it is through corrections or behavioral health or mental health services, how we make sure that we set up a workforce so that they can get the people who need the access who aren't getting it right now, and then that would be a subsequent piece. So that's where I'd like to start, and I do think this is going to be a very big task, but I'm excited to work with everybody who's on here. I think everybody was selected for very specific purposes.
Thank you. Representative Noble?
Thank you, Chair. My name's Ron Noble. I'm the state representative from District 24, which is McMinnville up to Hillsborough, both Yamhill and Washington counties. And I won't, I think what's been said, excuse me, probably is exactly what I've been thinking. But I would add that my experience really is professionally as a professional layperson, and law enforcement dealing with people in crisis, because we don't have a system that deals with issues that they have before they become critical. Everybody in here knows that we made the right decision in deinstitutionalizing people, but we still have not dealt with how to best serve these people. And that's my experience when people are in crisis. So my focus will be really how do we keep people from getting to that point and provide the services they need so they aren't in crisis, where then we have tragedy. That's my lens that I view, and looking forward to participating on this group.
Thank you. Representative Moore Green?
Good morning. Thank you, Chair. Raquel Moore Green, House District 19, Salem, Almsville, and Turner. I am brand new. I think this is about day 55 for me. And in thinking about what the priorities would be, I would echo everything that has been said here, and there are obviously people who have much deeper understanding of the issues than I do, but some of the priorities that I think will be important for me, at least, to get moving forward is the systems that are currently in place. You know, what do we have, and what are the associated costs with those? I want to make sure that our committee is communicating with the Senate subcommittee and the governor's task force on behavioral health as well. Big on public-private partnerships. I think here locally in Salem that has worked very well. One example is Union Gospel Mission here in town, who does deal with the homeless population and some of the more difficult individuals to place into housing and into services, and it's been very successful. And I would like to think that there are things that we can do, things that are being done in other communities that we could replicate throughout the system. And I also think that we need to be mindful of the budgetary impact and the long-term financial stability of the programs and the services. I feel strongly that this is an area that if we fund it, it deserves predictable and reliable resources. We're dealing with people's lives here, not only their lives, but the lives of their loved ones and their family and friends and employers. So I think that's terribly important as well.
Thank you. Representative Williamson?
Thank you, Chair Greenlick. Jennifer Williamson, House District 36, which is northwest, southwest, downtown west side Portland. So for me, I have a district that probably has the most visible population of people in crisis. And so from a constituent perspective, I hear from folks on the daily about people in our community who are in crisis. I think everybody knows that I'm a lawyer and that I was in private practice, but I think people don't realize is that I worked at the Department of Education and was a higher ed administrator before I came to this august body. And so education policy is very important to me, and I think we have an incredible opportunity with the Student Success Act and additional funding around how we deal with our kids and our students around mental and behavioral health. And so I'm interested in the overlap of that conversation with this committee and how we think about that. As chair of the Judiciary Committee, looking at the way our behavioral mental health system overlaps with our criminal justice system, as everybody has talked about, I really think that our criminal justice system is the final safety net in our communities. And so because we lack the kind of services, continuity of care and the like in behavioral health, those people end up in the public safety system, and it is not a system built for people in crisis. We passed Senate Bill 24 last session that is looking at how people go to the state hospital, and we made big changes in a big system, and there I think is work to be done as that system is rolled out on whether or not we got it right. My guess is there are parts of it we did not get right, and we won't know that until it's rolled out in the various counties. And we see how the use of community level care works in conjunction with the state hospital and our aid and assist population. And thanks to Representative Greenlick, who has worked on that issue for a very long time, we made great strides last session, but we know there will be tweaks to that system that we need to address. Last session, we also passed a bill to look at jail healthcare and jail suicides, which in the Northwest is one of the leaders in jail suicides in the country. And we are going to get new data on why that is, because we've never had a window into that population until, we won't have a window into that population until we receive the reports back from our communities and our jails about what's happening with their mental health. Women in crisis. Women are the fastest growing population in our prison system, and the vast, vast majority of them have behavioral and mental health issues. And how are we dealing with that subset of our population? And finally, many of you know that I work on gun violence prevention, and suicide is what drives our numbers on gun deaths in this state, to the point that we are leading in many of those categories. And so how do we look at conversations around access to firearms with our and how it overlaps with our mental health system? So just a few things, Chair Greenlick, that I would like to address in your committee.
Maybe we can get those done before.
I think we can do them tomorrow.
I'm Mitch Greenlick. I represent House District 33, which is the next door neighbor to Representative Williamson's district, Northwest Portland out into Washington County. I think about the time I was just calculating. I've been working in the healthcare system seriously about 65 years now. And it's been interesting to see the change in a variety of things, but in this system particularly, the way people with mental illness were treated was they were thrown into a state mental hospital, the door was locked behind them, and they were forgotten. And in the end of the 20th century, there was a reform movement that came about. It was an attempt to close the snake pits, which is what these institutions were referred to at that point as a part of the reform movement. And the notion was that we would create a community mental health system that integrated the care of people that were currently thrown into these state hospitals. And then we would open the doors of the state hospitals, the snake pits, and let the community mental health system take over. Well, we did open the doors of the snake pit. In Oregon, we closed Namish in, I think, 1995, which was our version of the snake pit at that time, not quite as bad as others. But we did close it, but we never created a community mental health system to go with it. And we're now suffering the consequences of that because we don't really have any idea of where we should be going. We have a suspicion that those chronic schizophrenics that are living in the park under the bushes probably aren't being treated very well. But on the other hand, we don't have, until they get arrested, we don't have much to offer them. And if we don't know where we're going, then any road will take us there. And what I hope we can do in this committee, because there are a lot of important one-off efforts going on that will stand in their own right, but there isn't any way to get a coordinated effort that will take us, say, over the next decade in a purposeful way with a clear-cut understanding of where we want to go and how we can compare this thing for workforce with this thing for children's mental health with this thing for prison mental health. And I think we could make a contribution in this committee by creating a roadmap that will help us get to where we want to go and get some consensus on what the system, the ideal system looks like, and how to create some priority to move us in that direction in a consistent and coherent way. So I hope we have the ability to produce some overarching insights into where we want to go. So as long as we don't know where we're going, any road will get us there, and any answer is fine. But I think it would be good if we could figure out how to create a roadmap that will get us somewhere, and I hope I'll be talking about that as we go forward. Well, we are right on schedule. I'm going to open an informational meeting. We're going to ask our friends at the Oregon Health Authority to talk to us about where we are and where we're going and what their view is to help guide us as well. You'll remember to introduce yourself.
Thanks very much, Chair Greenlick, members of the committee. My name is Patrick Allen. I'm the director of the Oregon Health Authority. I'm joined today by Steve Allen, who's the authority's behavioral health director. We hope over the half hour or so we have to kind of give you a grounding or a level setting in terms of how the system is designed to work today, a little bit about how it's funded and how those funds flow. But then really spend some time talking about how this system impacts the people who interact with it. And Steve will spend actually the bulk of our presentation talking about some preliminary ideas of what a vision looks like to move forward. Representative Salinas, not only did Vice Chair Hayden say most of what you were going to say, he said most of what I am going to say. And so I'll be able to keep my portion of the presentation pretty brief. A couple of points I want to make, though, before I dive in. One is that I'm delighted not only to be here, but that you're here, that you and your Senate counterparts have formed these committees to focus on behavioral health. I don't want that focus, though, to be confused with thinking about this in a silo. Behavioral health doesn't exist in a silo. It's deeply intertwined with physical health, with oral health, and everything that we do, we think about in terms of integration. You see on the title slide that behavioral health is part of the Health Systems Division. That's where the Medicaid program also lives within the Health Authority, and that's a conscious decision to keep those together to help facilitate that integration. I should also point out that Steve's position is relatively newly created within the agency. There was a reorganization that was done several years ago that took the old Addictions and Mental Health Division and broke it up and spread its parts around the agency. I think in a well-intended effort to try to foster integration, but it had the unfortunate effect also of making behavioral health disappear within the agency, both in terms of the visibility of the topic and the functions, but also accountability for the work itself. And so about a year ago, we implemented a new organizational structure to recreate a behavioral health program and reconsolidate those parts. And I'm delighted that Steve is now heading that program. And so when we think about any kind of a topic in the Health Authority, we really do always start from the triple aim of better health, better care, and lower costs. It's one of our touchstones to keep us from siloing the work that we do, and also helps us focus on the fact that if we pay too much attention to either of these three elements, we run the risk of doing grave damage to other parts of the system. If you think back to the days of managed care back in the 90s, when some of the same kinds of things, same kinds of tools we use today say, in terms of capitation payments and those kinds of things were created, there wasn't enough focus on better health and better care, and so those things suffered as a result of that. Chair Greenlick touched on this, and I want to go just a little bit deeper. The phrase behavioral health is actually pretty confusing. I came to the agency not knowing much about behavioral health. One of the things I learned quickly is everybody means something different when they talk about it, whether you're talking about schools or Department of Human Services, the criminal justice system. For us, behavioral health means essentially the same thing that Chair Greenlick outlined for you, the combination of mental health, mental illness, and substance use and addictions disorders, including gambling, which doesn't get talked about a lot when we talk about substances, but is also an addiction disorder. Co-occurring disorder is another phrase that we use to mean a diagnosis in an individual of both a mental illness and a substance use disorder. You'll also hear us talk about serious and persistent mental illness. That's basically someone who's diagnosed with one of a set of specified serious mental illnesses that include things like schizophrenia, bipolar disorder, anxiety disorder, schizotypal personality, those sorts of things. And those are all really in the young adult and adult populations. In the population of people under 21, we talk about serious emotional disorders, SEDs. And that really is a diagnosis that results in functional impairment that has a duration of over a year. And so the definition is somewhat broader in some respects, somewhat narrower in other respects. Now, it's important to note that in DHS, when we talk about behavioral health, we're often talking about something somewhat different. And in my spare time, I serve on my local school board, and same thing in a school setting. When we talk about behavioral health, we're talking about sometimes mental health and sometimes behavior, as distinguished from behavior that results from a mental illness. So kids who run away is a good example. That can be associated with a mental illness, but it can also just simply be a behavior that is trying to be managed through the behavior restoration services or BRS programs in DHS, or that schools try to deal with in that environment. In DHS, dual diagnosis doesn't mean the same thing it does for us where we're talking about mental illness and substance use. It means mental illness and intellectual or developmental disability. And so you may hear that phrase go by and it means something a little bit different in that context. And then finally, in the criminal justice system, there's an entirely different vocabulary around people unable to aid and assist in their defense, people who are guilty except for insanity, those kinds of things. So just some kind of basic grounding in the terminology that we use. I want to move to a kind of a schematic that gives a very high-level notion of how we think about how this stuff works. Any schematic is inherently oversimplified and raises questions and gaps and those kinds of things. And so I want to try to give you a grounding in this, but acknowledge that it ain't this simple. But when we think of the work that we do, we think largely in terms of three major groupings of work. It's around youth or children's mental health, adult mental health, and then substance use disorders. And those circles all overlap because the lines between adults and kids are not bright lines. Substance use issues often co-occur with mental health issues, and they impact each other in all three of those spheres. To the right-hand side, and we'll spend a little bit more time talking about who some of these organizations are, but we do this work as a health authority largely through coordinated care organizations who provide the mental health benefit under the Oregon Health Plan, community mental health programs, CMHPs, which are often providing benefits in partnership with coordinated care organizations using Medicaid dollars, and which are also directly funded by us through what we call service element contracts, and then a variety of other partners. Again, Vice Chair Hayden touched on the fact that we spend a lot of money on behavioral health in the state, $3.2 billion in the current biennium. The dark blue box represents the Medicaid portion of that. Coordinated care organizations enroll about 85% of the people who are on the Oregon Health Plan. The spending in behavioral health on Medicaid is rather larger in the non-CCO portion than other types of Medicaid spending, because there are things like behavioral health drugs that are carved out. There are direct contracts that the health authority has with a variety of service providers and those kinds of things. So that represents both CCO and non-CCO Medicaid spending. The bluish-green box at the top represents the state hospital. It's about a $500 million general fund allocation because of federal restrictions on Medicaid spending in what are called institutions of mental disease, IMDs. The spending at the state hospital is ineligible for Medicaid, even if the people who are there qualify. And so it's some of the most expensive health care on earth, about $1,300 a day to stay at the state hospital. And it's a finite resource, fewer than 600 beds. I think that's enough on, well, I guess the last point, one of the things I've asked Steve to help me understand, and we're working on getting there, and it again goes to Vice Chair Hayden's point, is that enough money? Is it too much money? Is it not enough money? We need to spend more money, or we need to spend it differently? That turns out to be a really difficult question that I'm still trying to get my arms around, having come to this not having a background in behavioral health. This may or may not be helpful. It's a schematic that tries to give you some sense of where the money comes from and where it goes. At the top of the chart, you see that there is federal funding. Some of that federal funding comes directly to OHA through a federal entity called SAMHSA, which is the federal mental health organization. We also get federal funding that is matched, that goes into the Medicaid program. In that state blue box, there's also state general fund that's added. And then the following the flow around, state money goes directly to the state hospital, goes to counties or other organizations that are charged by the county with delivering mental health services, and it flows in state match to Medicaid, both directly and through the coordinated care organizations. Private insurance also participates in the mental health system. It's one of the interesting areas where benefits under the Oregon Health Plan are actually significantly better than benefits in private insurance, which in turn are significantly better than benefits under Medicare. And that's one of our most growing critical problems, are senior citizens with mental illness and the lack of resources available for them. Then the purple boxes are the providers, the people who do the actual service, which includes community mental health programs, private providers, and tribes. Community mental health programs, CMHPs, are really one of the critical links in this system. They are most often the frontline providers of both ongoing and especially crisis mental health services, and they get funded for that both through coordinated care organizations and directly from the state. Just to take a minute to talk about coordinated care organizations and their relationship to the system. I won't spend a ton of time on this because most of you in other contexts have heard me talk about CCO 1.0 and CCO 2.0. I think the biggest difference as we move to the new round of contracts that begin in January is an attempt to really focus on the behavioral health benefit, focus on its integration with physical health, and the accountability of coordinated care organizations to deliver that benefit. In CCO 1.0, with a wide mix of approaches across the state, often that was a benefit that was delegated to another entity, and a little bit not only financially delegated, but sort of the responsibility was delegated. And what we're trying to do in CCO 2.0 is make sure that CCOs understand that whoever they're paying or subcapitating to or anything like that, they're responsible for the behavioral health benefit. And it's their responsibility to make sure that benefit is being effectively delivered and is well coordinated and is integrated with physical health. Last slide is about community mental health programs, and I think I've really already covered that. So with that, I want to turn the presentation over to Steve Allen. Steve's been with us for about 4.5 months now. He came to us from the Council of State Governments, where he ran projects nationwide on behavioral health justice reinvestment, one of which was in Oregon, in which you all approved a $10 million investment in and made a permanent program. He's a national expert, has a background as a practitioner. We're delighted to have him as our still new behavioral health director. Steve?
Yeah, thank you, Pat. Chair Greenlick and members, it's my pleasure as your new Behavioral Health Director to have time in front of you. I think as someone who's worked in this field for more than 25 years, I spent a lot of my early career sort of a voice crying in the wilderness that these are systems that clearly need change, and no one was listening. And I'm so grateful that in Oregon, it's clearly people are listening and are ready for change. And one of the things that folks have been asking me since I got here is, well, Steve, what's your vision for behavioral health? And initially, my responses have been, well, it shouldn't be Steve Allen's vision, first of all. It should be Oregon's vision. And I didn't walk in with a vision, and I don't have one yet. But I also came to appreciate that folks in the legislature and others are really looking for some central ideas to help create change in a way that leads to a more cohesive and coordinated and efficient and effective system. And it has, in my conversations with you and with your colleagues and other stakeholders around the state, it has, I think, often come to my attention that people feel like you're just solving the problem du jour, whatever the crisis is, and in a particular way for a particular reason, but in a way that doesn't feel like you're driving the system towards something better in 10 years. How do all these changes fit together in a more cohesive whole? If you look at the amount of expenditures in behavioral health and the healthcare system and as a whole, what are those additional dollars buying you? Is the system actually better for having made those investments? And so I've come to realize that I think part of the role that folks expect from me is to help guide those conversations with some clear ideas. And so you'll hear as part of my comments where I've landed on that. It is a work in progress, so I'm very happy to hear your comments and your suggestions over time. But that's something I feel now responsible for driving, and you'll see an early vision of that today. The reason people are up on the screen, I think, goes to Representative Hayden's point, is that healthcare in America, and including here in Oregon, is highly complicated. It's complicated for good reasons, and frankly, I don't see it becoming less complicated as a system as a whole anytime soon. And I think you'll see in this vision concept that I'll lay out, what I think is critically important is to focus back on the people, because it's really tempting in the midst of all this complication to focus on what I'll call the healthcare machinery. So that machinery is in place for a reason, but if we keep tinkering with the machinery without a clear focus on why we're tinkering with the machinery and what we want it to look like in the future, I think we can end up with a lot of cobbled changes that don't lead to a more cohesive approach to healthcare. I'll backtrack to the slide that Pat just went past, but I want to start here. And these ought to look familiar to you because these are things that have come to your attention as legislature problems, both in the past and the present, that you're involved in. It goes to this point that we're trying to solve this problem, this problem, this problem in ways that don't lead to a more centralized approach. I'll also put this slide on the screen because if you think about a couple of our current challenges, the aid and assist population and the out-of-state placements for children, one of the things that you'll, I think, appreciate, that I've come to appreciate, leads to the next slide that I'll go back to, is these are multi-system involved people. And unlike something that's fairly basic and maybe severe in healthcare, like breaking my leg, I go into the hospital, a doctor or nurses see me, they set the fracture, et cetera. That's all done within a fairly simple system, right? A hospital system that's all under the umbrella of one organization, payments through one simple system, communication, collaboration, coordination is fairly basic because they're all under the umbrella of HIPAA, so they can freely communicate. Well, that's often not the case, especially with multi-systems involved and complicated people like we see with the children who are in these out-of-state placements and for people in the aid and assist. The screen shows you what's very common with these situations, that there may be multiple folks involved, including friends, family, mental health, substance abuse providers, folks may be justice involved, so court involvement, landlords, employers. And in an ideal system, in a better system, in a system that I think we ought to be driving towards, those interactions are much less fragmented than they currently are. And in fact, I see system fragmentation, not just here in Oregon, but around the country, as a key reason why our investments in behavioral health are not working very well. And just a quick example, let's say that you have mental health services that are competently provided for the person, but they also have addiction services, and they also have housing needs and employment needs, et cetera. If all of those folks aren't working together, that intervention in mental health that may be actually doing some good gets undermined by the lack of coordination, collaboration, and communication by everyone else. In other words, those resources can quickly evaporate and not do any good. Same is often taking place with aid and assist. Folks get high-quality care at a state hospital at a cost of over $1,300 a day, but what happens
Could you
afterwards?
just comment on what aid and assist is in case everybody...
Yep. Thank you, Chair Greenlick. So aid and assist for folks not familiar with that area, when someone is arrested for a crime and it's determined through an evaluation that their mental health is such that they can't consciously or competently aid and assist in their own defense in court, they fall under what's called a 370 order in Oregon and are entitled to mental health services to help them restore their competency so they can meaningfully participate in their defense following. And that's commonly a track for people who go to the state hospital for those services, although those services do not need to be provided in a state hospital in all cases. Some people are, their conditions are such that they could be competently and effectively treated in the community.
If I could just add to that quickly, because it's important to note, services for someone who is at the state hospital or elsewhere on an aid and assist order are referred to as restoration services, which is well short of comprehensive mental health treatment. People in the state hospital under a civil commitment or guilty except for insanity are receiving a comprehensive set of treatments and services for their mental illness. If you're there, as half the people in the state hospital are today on an aid and assist order, you're being psychiatrically stabilized and being provided minimal legal education so that you're able to participate in your trial and get sent back to jail and stand trial. It's a very different paradigm, and that's important for you to know as we think about these systems.
Yep. All the beds are taken up with forensic patients, either in the GEI or the aid and assist population. We have, what, less than 100 civil commitments in the hospital now?
I think it may be about 100.
Thank you, I'm sorry. Go ahead, Steve.
Yep, you're welcome. So here is the iteration of what I'm thinking of as a vision or principles under which change could cohesively take place here in Oregon. And it really comes down to 3 words, and I'm going to elaborate on those 3 words as principles, and then I'm going to apply them in 3 separate situations. One is at the individual patient or child level. A second is at the workforce level, because workforce is clearly a challenge here in Oregon. And the third is from a law enforcement or courts perspective, because there's an interest in that perspective here. To just give you an indication of how you can be, as legislators, thinking about how to apply these. So first of all, the 3 words are simple, responsive, and meaningful. And simple simply means simplicity of access, and I'll give an example of that in a minute. Responsiveness means actually providing services in a way that takes into account individual differences, such as age and gender, culture, and the array of challenges that you might have as an individual. And meaningful is meant to capture something that I think has been fairly elusive in healthcare and frankly in other areas in the state government. I think generally we just don't measure things very well. We collect a lot of information in healthcare and a lot of information as a state, but not much of that information, frankly, does much good in terms of informing whether we're getting much for our investment. So what are we buying? What are we getting? And what we're getting, is that something that's meaningful for the state, meaningful for taxpayers, and meaningful for individuals that are being served by the system. So turning to this next slide, is talking about this on an individual level. So in terms of simple, again, simplicity of access, no wrong door, clear, prompt access to care, and that's not the case here. And if you think about those people going into the system on aid and assist, or the child's in out-of-states placement, and you think about their trajectory into the court system, very often it's the lack of this straightforward access to services. In fact, too often I'm hearing here in Oregon that there's people with these complex multi-system involved issues that have just the opposite. They're blacklisted essentially from services. These are people who are said to have burnt their bridges. Well, that's simply irresponsible and not very helpful from my perspective. These are people often who are kicked out of programs because of the behavioral health problems that they have, just exhibiting those symptoms. So kicked out of my housing placement because I'm drinking. Well, I came into those services because I have an addiction. That doesn't make much sense. I am angry and I holler at the person providing care to me, or when that may well be part of the challenges that I'm dealing with and the reason I'm homeless and the reason I haven't been accessing services. What are we doing to be responsive to that person's needs? So responsive is very often in our systems as they are now, is you go into an agency and someone offers you services, but those services are, what you get is what we got, versus based on an assessment of what you actually need, based on age, gender, type of situation that you're in, the variety of services that you might need. And meaningful, are we actually focusing on what is meaningful to the people we're trying to provide services for, something that will actually make a difference in their lives? And from an adult perspective, it might be a mom who's lost her kids because of her addiction or mental illness or both. Are we helping her get her kids back? Is that what's driving what we're doing in a collaborative way across all of the individual agencies and entities that are interacting with that person? Or for a child who may have been expelled from school because of behavioral conditions that are linked to trauma or to addiction or to mental health, are we helping them get their friends back? Are we helping them reintegrate into school? Things that are meaningful for them. And I think if we get all of these things right, our significant investments in healthcare will pay better dividends. Let me give you one more example. So I was recently at the Blackburn Center for their opening as part of the Central City Concerns. And Rachel, the CEO, told this story about a woman who came into services before in their sort of soft opening period. And this woman had never been to Central City Concerns. She had never been in the building before. It had just opened. She didn't know where to go, and she had a wide variety of challenges that she was trying to deal with. And so someone on the street says, well, why don't you try that new building, see what happens? So she walked in the front door, went to the receptionist. The receptionist said, how can we help you? So the woman talked about she hadn't eaten recently. She didn't have good clothes. She had a mental illness, didn't have her medications. She was struggling with her addiction. She didn't have a place to live that was safe. And so within a few minutes, they took her to a room not 20 feet from where the reception desk was, and they, over the course of the next couple of hours, they surrounded her with people who could help. So she saw the nurse, and she saw the doctor about her meds. She got some food. She got something to drink. She got clothes. She got hooked up so she could have at least temporary housing in a safe place. All of this took place while the woman was saying, really? You can do that? You can do that? Wow, you can do that? So that's simplicity of access at its finest, and I think that's what we should be driving for. All you have to do is show up, and more, those interactions were responsive to what she actually needed and had a high chance of improving her life. And if we're doing that, she's likely to show up again and get the rest of what she needs, the help that is harder to get, which is to stay engaged in treatment sufficiently to help beat her addiction, to help her stay on the road to recovery, not just show up one time, but multiple times over weeks, over months, over years, because that's the trajectory of healthcare. In the investments we currently make, often we get a piece of the puzzle right, but we don't get the rest of the pieces right, and that results in huge waste of healthcare resources because the overall picture doesn't result in long-term meaningful change for people. Let me switch this now to workforce. So you can see how
We've got
this...
about 5 minutes, Stephen. We won't have time for questions, but we'll have you back in November for questions.
Thank you, Chair. I'll do this fast.
Go ahead.
So workforce. Are we making our system simple so that people who get into this work can actually do their job? What are the barriers that we need to take out of the way so that more of their time can be spent eyeball to eyeball, helping people make meaningful changes in their life? Are we responsive to the needs of the workforce? We have a huge problem with recruitment and retention right now. It's because we're not being responsive to what people need to stay engaged in this work in terms of training, clinical supervision, supports, paying them well enough to keep them in this. And are we doing this in a way that they continue to find the work meaningful? Because that's why people get into this work. It's not because of the money, it's because they want to help people. And too often, the reason people are leaving the work is because they no longer feel like they're doing something meaningful to affect people's lives. And law enforcement and the courts, are we making access to services that people need and facilitated by our frontline law enforcement agencies simple to access? In most cases, not. It's a key source of frustration by the courts and by law enforcement right now. Are we actually being responsive to what law enforcement and the courts actually need to do their job as front lines in this work right now? And I think the answer right now is no in most cases. And are we helping them be a part of a system that provides meaningful impacts for their communities? Because that's what law enforcement and the courts are designed to do, to serve, to protect, and to assist, to solve community problems. And right now, we're not giving them the tools to do that meaningful work. And as a legislature, I think you can use these three principles. When you look at the avalanche of proposals that's likely to come out of this short and upcoming long session, as you look at them, ask these three questions. Will this proposal, will this investment in front of us result in some simpler access to needed services? Is it responsive to the needs of people who are coming in front of us and the system that needs to support that? And will it result in meaningful changes in improving the lives of people in Oregon and the people that need to work there? So those are my comments. Thank you so much for your time.
I'll ask, we've been promised 3 hours in November, so we'll ask you back for, and you'll probably have solved the problem between now and November anyhow. It'd be very useful. In the meantime, if you take the opportunity to brief any of our folks who are interested in talking to you, I hope we'll take an invitation for you to talk to us individually. I'd like to raise one question before we go. I don't want you to answer, I just want you to think about. I was looking at, I think it was an NCSL document the other day. There was a little factoid on the right side of it. And it said that when you looked at adults with mental illness, 50% of them had had a diagnosis before they were 14 years old, and 75% of them had had a diagnosis before they were 21. That says something profound about prevention, it seems to me. It gives us a clue to something, and maybe we can explore that more in depth as we move forward. But that was pretty startling statistic. It's not exactly right, but it was something like that. So that can be on our future agenda.
Chair Greenlick, I think both prevention and how to think about managing a chronic illness in ways that we often don't apply to mental illness, I think.
Well, thank you all very much. We'll see you an hour tomorrow at 11, is that?
That's correct.
We will adjourn until 11 tomorrow. Very